Good afternoon, everyone. I will be sharing about another type of newborn screening, but this time it is not yet part of the PhilHealth covered newborn screening. However, hopefully soon it will also be, but we can already start this in our institutions if we are well aware of why we need to do it and if we are willing to do it. So the objectives of the talk this afternoon is to define what is critical congenital heart disease, of course, to discuss the role of pulse oximetry in screening, and we will go over the steps in screening for this critical congenital heart disease. So we will probably deal more with the latter part than the first few. Okay, so when we talk of congenital heart disease, it's actually the most common birth defect in infants. We all know pag may butas sa puso, right? We already know that they probably have a congenital heart disease. But notice, even a critical congenital heart disease has quite a high incidence. It's 2 to 3 in 1,000 live births. So that's not an insignificant number, considering that there are a lot of babies being born here in the Philippines. And the sad thing is, up to 50% are missed by the current screening methods, such as the physical examination before discharge, and even fetal echo. And of course, fetal echo means that we do the 2D echo while the baby is still in the womb of the mother. But not all women can have that, and not all facilities have fetal echo. And even if we do these things, so even before the baby is born and before the baby is discharged, 50%, imagine that, half of them are still missed by these methods. That is why okay, sorry. We need to go to the definition of what critical congenital heart disease is. So it is a heart disease that requires surgery or catheter-based intervention in the first year of life. Some of them actually need these interventions within the first few months of life. So that's how critical they are, because if they do not have the intervention that they need, these diseases are life-threatening, because usually they are hypoxemic or they have very low oxygen levels, or sometimes in other conditions, it can lead to shock. So many of these critical congenital heart diseases depend on the patency of the ductus arteriosus. As we know, the ductus arteriosus is a normal structure while the baby is in the womb and even in the first few days of life. But the normal course of this ductus is to close after a few days. So it is critical that we learn if the congenital heart disease is dependent on this so that we can do something about that ductus closing. Okay, so some of the critical congenital heart diseases, it's a long list, and it's not even exhaustive. Suffice it to say, remember the last 5 ones listed here. So these are the more common, the 5 T's of cyanotic heart diseases, okay? And just to give you an idea how to remember them, there's truncus arteriosus with just 1 trunk coming out of the heart instead of 2. Transposition of the great arteries, you have 2. The 2 great arteries interchanged in their anatomic positions. There is tricuspid atresia. The tricuspid is closed. There is tetralogy of Fallot with 4 components. And the last one is total anomalous pulmonary venous return, which has 5 letters in its name. So it's easy to remember them. 1, 2, 3, 4, 5 T's of critical congenital heart disease. And they're still the most common. Okay. Pulse oximetry now has been found that to be a very good screening tool, because it has a high sensitivity and a high specificity. Okay, so if you see here, it does not only detect those who have congenital heart disease. Look here, there are only 8% of those who failed the pulse oximetry screen to have congenital heart disease. But look at the majority. 71% of them have other conditions. It's not congenital heart disease, but other conditions that are equally life-threatening that need immediate intervention as well. So those are neonatal pneumonia or PPHN, and of course the others, they could just be hypothermic, or there's transient tachypnea of the newborn, and the baby is still transitioning in its circulation. So other disease entities that pulse oximetry can detect, of course, we have to work the baby up for this. Hemoglobinopathies is one. There can be other congenital heart disease, but not critical. We already mentioned some of the lung diseases, and of course, other causes of hypoxia are there as well. Okay, so now we go to the how now. So we know that it's very important because we need to detect them so that we can intervene early. So who should be screened? Generally, healthy newborn infants at least 35 weeks age of gestation and with no identified comorbidities are the ones that we screen. Why 35 weeks? These are already near term and they have less comorbidities. Usually, if it's 34 weeks or below, they usually have comorbidities that would require them to be admitted in the nursery. So if they are there, of course, they are not healthy. Okay, we have to monitor them closely. And so they, of course, will receive monitoring by pulse oximetry. But when we say screening, they actually do not need the pulse oximetry, clinically, but we're going to use that pulse ox to screen them for something that they may have, even if they don't have symptoms. Notice this, 24 hours after 24 hours of life, and they should be calm and thermoregulated. Ideally, they're not breastfeeding. There have been studies to show that when they are breastfeeding, the SATs can go down a little, so it can lead to a false positive. So we want them just calm, awake, and thermoregulated. And notice, after 24 hours of life is also the time that you do the prick for the heel. So some centers that are already doing this, they start with the pulse ox screening before they do the newborn screening. Okay, so that you can do the procedure at the same time. They can be done by the same person. Okay. I want to show this picture first so that we understand why we are doing the screening on the specific extremities that I'm gonna mention later. Okay, so here is the aortic arch coming out, and this is now the descending aorta going to the foot. So notice, the first branch is the brachiocephalic artery, which will give rise to your right common carotid artery and right subclavian artery. The right subclavian is the one that will supply the right hand of the baby. Okay, it's very rare to have a congenital malformation in this area, so that the right hand will receive oxygen from here. Okay, but notice, look at the left subclavian artery. It's very close to the ductus arteriosus, so that if there is a reversal of the shunt of the ductus, meaning from the pulmonary artery shunting out to the aorta, it can actually give a lower saturation in this area and even in the left hand of the baby. So we do not want to take the saturation of the left hand of the baby, especially if it's very close to the ductus, because that can give us a false positive result. So we want to take the saturation here in the right hand of the baby and compare that with the saturation there in the foot of the baby. And that's why these are the areas where we get the saturations. Any foot, it can be left or right, and we term that the postductal saturation. And the right hand, not the left, remember, because it can give us a false positive result. So that's now the preductal saturation. So there are two SATs that we're going to get for the pulse oximetry screening. Okay, so what are the equipment that we need? Of course, our pulse oximeter. This can be the bedside one or the handheld one. And we have to have a neonatal probe. I know na uso na ngayon yung clip-on na pulse oximeter, and there's even the small ones for the newborns, but that's not very accurate still, especially for a newborn that's moving the extremities all the time, you know. So we really have to have the probe that's specific for neonates so that we can get an accurate result. I have already incorporated in my lecture how to a video so that we can see how it is done. So how is the screening done? Of course, we prepare all our equipment, okay, and the baby as well. We have to sanitize ourselves and the neonatal probe before we hold the baby. Of course, if we're using a new probe, then that's even better. But I know not all hospitals can afford a new probe every time that they do the screening. Just make sure that you clean very well the probe that you'll use if you're using it for multiple babies, so that iwas po tayo sa paghahawa-hawa. All right? So we screen the foot first. Okay, why? It's kind of hard, you know, babies' hands are fisted. So if you try to open those fists, you can make them cry. So try to do it first on the foot because that's less invasive for them. You know? And put the probe on the lateral side of the foot. Okay, let's watch the video for that. Okay, so as you can see, the probe, the light is here on the lateral aspect of that foot because we want that transmitter to be close to the skin of the baby and not being lifted off. If we put it on the medial aspect, there is the arch of the foot that can push that transmitter away. Okay, and make sure that if you put the transmitter here in the bottom, the receiver should be there on top, directly across it. Nakuha niyo po? The transmitter is on the one side and the receiver is directly on the other side so that it can receive the light being transmitted. I've seen some people put the transmitter on the lateral and then the receiver on the top of the foot. So hindi sila magkakakitaan. So we need to make sure that they are in line so that the receiver can receive the light and be able to record the SATs accurately. Okay. All right. So we said to screen the foot first, and we have to wait for a steady signal on the pulse oximeter before we record the readings. Sometimes the initial reading is not really very accurate. So we have to wait for the signal to be steady. So look at this one. Okay, did you see that? There is already a steady signal there, but the previous signals there are still a bit chaotic. So we want to see a steady signal for several seconds. Sometimes we have to wait for a few minutes just so we know that we are getting the right saturation. We have to be sometimes patient with the babies because they do move a lot, right? So it doesn't really take an hour to do this, you know, it's just a few minutes. So hintayin na lang to make sure na the pulse oximetry signal is very good so that we know that the saturation that we're getting is really the accurate one. Okay, so after screening the foot and recording the reading from there, we now screen the right hand. Again, the reminder here is to put the probe on the lateral aspect of the right hand rather than the medial part because the thumb is there, and if it's not properly put, that can lift the probe off the skin of the baby. So as you can see in this video, look at that. The baby's hand is fisted. So medyo nahirapan yung naglalagay. Oh, yun, binukas ni baby. So if you did that first before you did the foot, ma'am, baka umiyak na nga yung baby, no? So we want to get at least one SATs first, saturation first, and then we can do this other one next. Okay, and again, it's the transmitter is here on the lateral aspect, and the receiver will be there on the immediate opposite side of that transmitter. Okay. All right. Once again, we want to wait for a steady signal before we record the reading. Okay. Okay, now we go to the interpretation. So I hope you got it, right? We start the screening with the foot and then we go to the hand. So how do we interpret it? If both the saturation of the foot and the hand are 95% and above, especially if you're in the sea level area, then this is categorized as pass. So you record the results in the chart of the baby and then notify the parents that the baby passed the pulse oximetry screening, but not all heart defects can be picked up by the screening. So even if they pass the screening, there can still be non-critical congenital heart diseases that may be missed. So pwedeng may VST pa or ASD later on, especially if there's still no murmur at this time, they can still have symptoms for those later on. Sorry, I forgot this one. Also, there has to be less than or equal to 3% difference between the readings of the foot and the hand for them to pass. How about the other one? So what if one extremity has a low saturation, but the other one passed? So look at this. The foot passed, but the hand is less than 95, or the other way around. The foot has less than 95% saturations, and the hand is the one that passed. And there is a greater than 3% difference between the two readings. This is where we have to screen again. So after 15 minutes, we can already do that rescreening. And if it's still the same, this is the time that we call them failed exam. Okay, but if they pass, meaning both saturations are 95 or above, and the difference now is 3% or less, then they already passed the rescreen. Okay, some protocols can require you to do the repeat after 1 hour. They can also require you to repeat twice. So there is a second reading and there is a third reading if there is still an unacceptable or not passed result. However, this one is one of the simplest protocols there is. I think it's called the Minnesota protocol. So it's just after 15 minutes and it's just one repeat. And after that, you already call whether the patient has passed or failed the exam. Okay, the last one, of course, is if the saturations of the hand or the foot is less than 90. So 89 or below, that is already an outright fail. So you don't need to repeat the saturations here. You already inform the primary care physician so that they can check the baby. So maybe there are crackles, or maybe the patient has respiratory distress or some other sign or symptom that they need to be treated for. And it's not necessarily immediately a congenital heart disease, but the primary care physician will have to evaluate for that. So if the primary doctor or pediatrician thinks that the baby needs an echo, then they can refer to the specialist, to the cardiologist. So just to summarize again how to interpret, okay? So if the readings, let's start here from the right side. If the readings are greater than or equal to 95%, and there is 3 or less % difference between the two of them, then the baby passes the test. However, if the readings are between 90 and 94%, okay, or if there is greater than 3% difference, then we have to repeat the protocol in 15 minutes. If it's still unequivocal, that becomes a failed test. But if the results becomes normal, more than 95% and above, or less than 3 or equal to 3 difference, then the baby passes. Of course, we remember that if it's less than 90% saturation on any extremity, that's an outright failed exam, and we have to refer to the primary care physician. Okay, so I hope we understood that. It's actually quite simple, and you can finish this exam in like 5 minutes, or if you have to wait for the steady reading of the pulse oximeter, then maybe it will take you a little bit longer, but definitely you will not need an hour to be able to do this exam. Even the repeat, it's just in 15 minutes, then we can already advise for what is the next step to be done for our babies. So as simple as this, I hope that we will start with this screening, even if it's not yet in the PhilHealth package. Our society, as well as the National Institutes of Health in UP Manila, are working so that this can also be included in that newborn package for babies. So thank you for listening.